Hi, my name is Kyle Pate, and I will be presenting my abstract on standardized risk assessment prior to MRI, improving communication for better safety outcomes. Poor communication between MRI staff and inpatient nurses at the time of handoff care was identified as a key contributing factor leading to respiratory distress safety events in MRI. Ideally, we could identify these patients prior to imaging and consider interventions such as alternative imaging, nursing support, or daytime anesthesia support. However, these all come with their own resource limitations. This quality improvement initiative was designed to improve communication between the inpatient team and MRI department and create criteria to determine if an inpatient would be safe for unmonitored MRI. MRI technologists and floor nurses were surveyed to identify common issues which increase the likelihood of poor MRI tolerability, longer imaging times, and poor safety outcomes. This MRI screening safety form was constructed from that feedback to be completed prior to calling the patient for their MRI study. The first section of the form addresses issues of respiratory status. The second section addresses ability to tolerate the exam, and the final section further clarifies the plan for the patient. Given overall rarity of reported severe safety events in MRI, data was also collected regarding non-diagnostic imaging pre- and post-intervention to serve as a proxy measurement for success in identifying patients who were poor candidates for MRI, and thereby potentially at higher risk for poor safety outcomes. The institutional imaging reporting database was queried using the above search terms. Reports were individually reviewed following the intervention and 1 year prior to the intervention. Analysis showed a trend toward decreased number of non-diagnostic examinations after implementation of the screening form, although the change was not deemed statistically significant with a p-value of 0.39. A new standardized workflow centered around a screening form has created a consistent transmission of relevant safety information between caregivers. Evaluation of proxy data showed a trend toward decreased numbers of non-diagnostic studies without statistical significance. However, other proxy measures likely exist within the reporting data. Our next steps will be to identify patients called back for repeat studies using DICOM metadata. We will also work with nursing to collect additional data on the use of IV Ativan since implementation of the screening form, and aggregate incident reporting data on sedation-related safety events. In conclusion, an MRI safety screening form can be implemented with buy-in from nursing, physicians, and technologists with possible benefits for patient safety. Future investigation will focus on aggregating DICOM timestamp metadata for further determination whether improved communication has translated to a reduction in incomplete or repeat examinations, and thus improved exclusion of patients who are poor candidates for MRI. Thank you.